All right. Uh-oh. The stream is going okay, I hope. Uh-oh. Okay, let's hope that this... The stream is going okay, I hope. Okay, let's see if this works. Yo! Join the live stream. Okay. If you have an account on YouTube, could you sign in so that I can actually have feedback? I don't want to just talk to myself in a room to a microphone alone, right? Let me know if also it'll help me if there's like if anything drops out or if I cut out in any way. If there's any like background noise that you guys don't like, go for it, right? I don't know why there's a shirtless man and like Overwatch stuff as the thumbnail, but you know, whatever happens. Either comment here on the live chat, for example, say something, right? Or actually comment on Facebook, because I don't know, like you'll figure it out, I hope. How do I see how many people? 12 people watching now. We'll start when the first person says something in the live chat. How's that? There you go. Incentive to actually participate. Unless it's fucking up, then it's my fault. I shouldn't swear. It's recorded. Buck off. I'm alive somehow. I heard that your CIP was about like asbestos or something. Bro, that's rough. That's rough. Maybe I should wear a blanket over my head so that I have better audio. Oh well. Listen, I've even got like some like I'm using some of my like Twitch experience and stuff, and I'm swapping over some screens. I'm ready to go. Hey babe, how's it going? Alright, let's see how many people are watching. We'll start when there's like 15 people, I guess. It's saying there's 14 people watching, so just one more. And I guess we'll start, because it is 8:05. But I did upload only like 2 minutes ago. Tim, shut up. CIP more like RIP. Tim, you're a hater. You know what they say. Dab on the hater. Alright, I'll start, because it's 8:05. And I don't think any more people will come. Alright. So, head and neck anatomy. Let's get my slides up. Right. Let me know if you can see my mouse, because that is actually important. So head and neck anatomy. Right, so with head and neck anatomy, I'm assuming that some of you guys have either perused through or read my PowerPoints, but it's a lot, right? But the first thing I want to kind of stress to everyone is that whilst it may seem like it's a lot, the most important thing you got to realize is head and neck anatomy is unlike other forms of anatomy in which you can attempt to learn it sequentially, but it's just inherently a form of anatomy in which you have to come back after you've learned some more. So like upper limb, you can learn the brachial plexus first, and then you can learn the forearm, and then you can learn the arm, and then the forearm, and then the hand. It'll make sense, right? You don't need to come back to it. Whereas with head and neck, there are some things I'll mention that you have never heard of before, and you'll actually have to learn that first, and then come back to have a full understanding of what I'm going to teach you in week 1, okay? So let's get it started with some general stuff. I love you too, Hip WN. I don't even know who you are. Okay, so I'm not going to mention this. Obviously, you do need to know which bones make what. What I will stress to you is what they might, what other Vespers might ask, okay? So, important things to know for this is just that they like to stress for you to know every bony part. And whilst I guess, yeah, that is important, I'd say the more important thing to know is the crazier bones and where that attaches to, right? So in your anatomy workbook, or at least in our anatomy workbook, and apparently in a previous exam, one of the things that they asked was that what other bones does the ethmoid attach to? Okay, number one thing I want you guys to see is where is the ethmoid, right? So ethmoid is obviously here, and 2, are you confident enough to answer where the ethmoid connects to, or the vomer connects to? Because if you aren't, well, that's 1 mark gone, okay? I think that's a really, really mean example, and I don't think they'll ask it for you. However, what is very, very possible, and I suspected coming up for our exam at last did not, was which bones make up the bony orbit, or perhaps which bones make up the formation of the pterion, because 1, 2, 3, 4, anything with 4, they can easily add a 5th one to kind of deceive you, and then, kind of get people to click that false option, etc. Okay, I think that's a very fair option to get you to find the orbit and the pterion. I think that's fair enough, right? So I think that's the only 2 things. Also, you do need to know which bones come from which pharyngeal arches. I'll touch on that in the embryology section. But yeah. Okay, so with this one, all you need to know is what is a suture, A, and B, the 3 main sutures, which is coronal. So the coronal is just the one between the frontal and parietal, right? The sagittal and the lambdoid suture. The 3 main sutures, that's all you need to know. And the 2 things you need to know is that pterion, 1, okay, and 2 is lambda. And why do you need to know pterion and lambda? Because anatomy is just an empty husk, right? It doesn't mean anything until you fill it with actual clinical knowledge. And the most, I can't even stress to you how buzzwordy this is, but and because this has been used constantly, is that pterion has the middle meningeal artery, okay? If you learn anything from this session, learn that just 1 point. The pterion has the middle meningeal artery, okay? And breaking the pterion and therefore breaking the middle meningeal artery will cause an epidural hematoma. Okay, just boom, boom, boom. 3 buzzwords. And I'll get to the hematomas and I'll stress that more, but just buzzword. Okay. The only important thing you need to know about the lambda is, as you know, it's called the baby's soft spot. And if you attack that point, well, don't attack the babies, but if you hit that point on a baby, it hasn't formed yet. It's too soft. You can break their brain. Right, there you go. Pterion. Deep pterion is the middle meningeal artery. Learn it, okay? It's also known as temple, which I found pretty interesting. Right. Okay, so with the cranial nerves, there's a lot of disgusting mnemonics. There's a lot of good mnemonics. By the end of cranial nerves or head and neck, you will know which one's which, okay? Like you don't need to know the mnemonics, right? The important things you do need to know for this, and I've highlighted in red, is that cranial nerves 3, 7, 9, and 10 are autonomic, okay? And this is so important that the reason that I've highlighted that is because there is a lot of confusion and a lot of overlap between which nerves do what. So a lot of, like the autonomic nerves, even though they arise from 3, 7, 9, 10, they travel along other nerves, okay? So as I'll explain cranial nerve 7 and how it travels, but you've just got to know that 3, 7, 9, 10, apparently the channels of the Australian TV, channel 2, channel 3, channel 7, channel 9, channel 10, or something. I don't know. Or maybe that was the vitamin K stuff. Right. So this one's not too important yet. It's more important in cranial nerve because the exceptions of the pontine medulla and midbrain pontine junction is important when it comes to stroke. But I won't mention that. Like, I won't delve into that because that's more important when you get to neuro. Right. I forgot about the Squidward. So DAP, okay, so the dural folds. What's important here? The reason that a lot of this is highlighted in red is because the dural folds are super easy to examine, and it's a topic that a lot of people seem to confuse pretty easily and pretty often as well. Because I know we kind of messed up on our MST because we didn't understand the layers that well. Okay, so the first thing you gotta know, the outer layer is dura mater. Okay, too easy, pretty easy to remember. This must have been revision for spinal stuff, right? So in the dura mater, you've got these dural venous sinuses. Okay, so is there a better picture? There it is. Okay, a dural venous sinus, and all that is just an accumulation of venous blood and CSF. Okay, drains into the internal jugular veins. What's important about the dural sinus? Okay, so dural sinus is within the dural folds, okay? So the vertical fold, as you can see, is it's the falx cerebri, and the tentorium cerebelli is the across one, okay? Those two are the two major ones. Some people, they really like to talk also about the falx cerebelli and the diaphragmae cellae, if I recall correctly, but the two most important is the tentorium cerebelli and falx cerebri. Buzzwords, okay? Buzzword is the tentorium cerebelli. If something goes wrong with that, it will impinge upon, if I recall correctly, the third cranial nerve. Don't quote me on that, but I'm pretty positive it's the third cranial nerve. Just note that, okay? If you look at any structure, you'll realize that an impingement an inflammation or anything, or a space-occupying lesion of the tentorium cerebelli will impinge upon the cranial nerve 3, I think. I think it's 3. All right. Another thing to note is this diagram. So for our exam, they were like, hey, we love the med students. We really appreciate them. Let's give them this diagram without any of these labels. And instead of saying label these components, they just describe the components. So they said to us, what is a small projection that allows CSF to recirculate? And it's just like A, B, C, D, E, F. And I'm just like, what are you on about, mate? What allows CSF? So know this diagram well and know what does what, okay? So this is the arachnoid granulation, which allows the CSF back into circulation, etc. This is the pia mater. You just know these parts, okay? Another important point to note is, I'm not sure if you guys have studied subdural hematomas yet, but once we get back into it, you'll realize the importance of this vein here. So note how this vein connects the dural sinus all the way down into basically the pia mater / cerebral level. Okay, and this vein is called this vein is called the bridging veins, and it'll come back. I'll mention it again when we talk about subdural hematomas. Okay. Once again, if you got any questions, just mention to the live chat or I guess comment on the Facebook. I don't know. Fucking weird. Right. So, general arterial system. What's important here? Okay, the important thing here is that they really love testing this in the anatomy sessions. Like all the anatomy tutors would be like, "What are the branches of the external carotid?" Honestly, I learned this. You really don't need to know this. Just know this general direction and where they go and the general names of it. Like superior thyroid artery. I can't even tell you what that's useful for now, but I can still recall the importance of occipital and posterior auricular, maxillary facial, etc. Right? So the two important ones are maxillary and facial artery, okay, and obviously the middle meningeal artery, which is an offshoot of the maxillary artery. Okay, obviously, what's important about the middle meningeal? It's behind the pterion, and it's important for the extradural. Just learn that, okay? General venous drainage, also the direction is surprisingly not clear to some people. So I just like to quickly go over that, right? So this is a superior sagittal sinus, and this is the inferior sagittal sinus, which is within the, what do you call it? The falx cerebri, right? So these two drain into one point, okay? As well as this straight sinus that connects the superior sagittal and inferior sagittal into this one point called the confluence of sinuses, okay? So it's just maybe not a buzzword, but it's something you do need to know. So these two, as well as the bottom one, sorry, the occipital sinus, I guess, they collect into the confluence of sinuses, which then goes to the side, goes laterally. I'm not sure if laterally is the correct term with the brain, but goes to the transverse sinus, down the sigmoid sinuses, and then it gets drained normally by the internal jugular vein, okay? Just note the direction. If they ask a question where it's like, which direction does the confluence drain? It doesn't go into the superior sagittal, they drain out into the transverse, right? Another important thing to know is that, this drainage system doesn't have any veins, it doesn't have any valves. And another thing to note is that the ophthalmic veins, which are all the way in the front of the face, is drained into the cavernous sinus, okay, which is the collection of sinuses here, okay? This is really important when we talk about the danger triangle, okay? So the clinical stuff. Just remember that. No valves, 1, and 2, the ophthalmic veins drain the face, which goes into the cavernous sinus, right? I remember this was actually the reason that I highlighted a lot of this red of external jugular vein is because they have asked this before, right? They really love asking about the venous system and the dural sinuses for some reason. So just remember that the external jugular vein, which is formed by the union of the posterior auricular vein and retromandibular. I know it's like very rote learning, but you just need to know that, okay? This is something you just need to know. Right, higher yield. Note that I didn't say high, like super high yield. It's just higher yield, right? Okay, so scalp. Obviously, you've covered this already, but the first 3 layers, not too important, really. The first layer is skin, second layer connective tissue, third is aponeurosis, and you do need to know which muscle forms the aponeurosis, though. It is formed by the occipital-frontalis, and hopefully you know that the frontal belly, as you can imagine, if that contracts, it wrinkles your forehead, and the posterior belly, or the occipital belly, if that contracts, it smooths out your foreskin. Wow! Smooths out your forehead skin. Sorry. I've been studying a bit too much of testicular cancer, apparently. Right. Gotta wake myself up. Alright, loose areolar tissue, the L. It's important because 2 things. And this is actually tested later on in week 3 or 4 or something. But basically, it's just loose areolar tissue that allows them... So the first 3 layers, basically 1 layer. It's really hard to separate them like this beautiful image here, but it forms one continuous layer, which glides along the loose areolar tissue, right? And the important thing you need to know is that one of the questions they'll ask is, what is the most dangerous layer of the scalp? And a lot of people will say the skin or the connective tissue, because that's what the vasculature is. The most dangerous area is the loose areolar tissue. It's because it has these things called emissary veins, okay? These emissary veins, which connects up the outer scalp into the actual dural sinuses itself. So you can imagine a connection that connects to the outside scalp to basically the venous collection that has the CSF and is right next to the brain is super dangerous when you get infection, right? So the infection can easily travel down into the dural sinus, and you are positively screwed when you get to that stage, right? So this is the most dangerous area. Perineum, obviously, is just a perineum, just a connective tissue. Right. Vasculature of the face, all you need to know is, not all you need to know, some easy buzzword stuff is what makes a scalp. They've asked us this before. It's you need to learn these 5, not these 5 arteries, but also the origin of these arteries. So the supratrochlear, supraorbital, obviously from the internal carotid, right? Whereas the external carotid forms the occipital, posterior auricular, and superficial temporal. So one of the questions could be just like, if someone lacerated their scalp, which of these arteries do not form the scalp vasculature? And it sounds mundane, it sounds stupid that they would ask that, but they've literally asked which of these do not form the vasculature of the nose, right? So it's very fair game for them to ask this. What other things important? Oh yeah, facial artery basically supplies a lot of the face vasculature-wise, but note how it turns over in the mandible, right? Turns like basically inside and then goes outside and up there. Some people like me have a little notch in their jaw that basically that demarcates where the facial artery goes around. I can feel like sometimes when I drink too much water or like exercise too much, I can feel the pulsation of that notch. So some of you have it. You can feel it on yourselves. Good thing I'm not there to see that. So the important thing to know is that if it's uncommon, but if you lacerate the bottom there, like it's dangerous because you lose vasculature of the face. But there is a lot of anastomoses. Once again, just want to stress pterion, middle meningeal. Okay. Causes extradural hematoma. Oh man, cranial fossa. I can't even stress to you how high yield this is. This is so high yield. This is why like everything is red. Everything, like even the title is red. I've just highlighted everything here. They asked us in a few they've asked us, I know this for a fact, and apparently some of the previous years, they've literally just given a diagram of this and they've just said label, right? Or they've asked like which they've asked us to physically label it, or they've labeled it A, B, C, D, E, or up to J, and they've described it, and they've been like this foramen accompanies the mandibular nerve, and it's like, oh, that's obviously the foramen of, right? You have to know this like the back of your hand, right? I'm not even going to go over this. I'm going to go over, because this is just rote learning, right? So, superior, I can't even go over this. You just need to know this. Note also that foramen lacerum, one of the weird descriptions was that doesn't transmit any important vessels, right? And I'm quoting this. You can't see the air quotes, but I am air quoting this. Is because apparently with the foramen lacerum, it actually no major vessels go through it. It's the deep petrosal nerve goes through the cartilage on the actual foramen itself, and the internal carotid goes over this. So it's basically like, hey, I'm a foramen, but nothing goes inside me, just like most of you watching. Carotid, internal carotid artery goes over the carotid canal in quotation marks, which is the foramen lacerum. Right. Another thing you have to know is, you think these foramens are important? No, these foramen are important as well. And perhaps they might even be questions on, note how the foramen magnum has CN11. But then you can also note how the jugular foramen has CN11. And then they might be like, yo, how does it exit from two foramen at once? What? Right? And you have to, that's when you have to actually know the course of the nerves itself, right? And that's why I'm going to describe it as succinct as I can. Also note how, this is important, in the internal acoustic meatus, which you would assume just to contain the vestibulocochlear, so basically the auditory nerve, also has the facial nerve, okay? And this is important because I'm going to describe to you the course of the facial nerve, right? So in this session, I won't touch on embryology, unless you guys want me to, but embryology is super high yield. I think of all the anatomy, we had 10 questions on in embryology, which is absurd, considering how little lectures we had. We had 2 lectures and it was 10 marks. Just calculate how high yield that is, right? So know the embryology like the back of your hand, because Lazarus is, all up in that bitch. So, second pharyngeal arch. And you know how they're how all the anatomy tutors are like, cranial head and neck is so difficult, learn it by principle, not the specifics. You know what? That's bullshit, okay? Because you know what they test? They don't test the specifics. They don't give you the muscles of expression and go like, what's the facial nerve? You know what they do? They give you the stapedius or the stylohyoid and they go, which one of these is done by the facial nerve, okay? So learn the specifics of which muscle. Learn that it's the posterior belly of the digastric, the stylohyoid, and the stapedius that is done by the 7th cranial nerve. I know it sucks, but it's important, okay? Another important thing to know is that facial nerve, despite the fact that it innervates a majority of the muscles in the face, does not do any of the sensory component of the face, okay? It is all done by, well, not all. Yeah, all. It's all done by the cranial nerve 5, okay? However, it does provide special sensation to the tongue by the chorda tympani. Okay, and this is a sentence that commonly comes up. Okay, the special sensation of the tongue is very, very commonly tested. And so you do need to know what does special sensation and general sensation. So like if I were to draw, right? If I were to draw something, how do I even do this? There you go. Time to do the fancy flash stuff. There you go, right? So if I were to like draw the tongue, wow, that is a horrible tongue, right? It'll be useful for you to draw this as well, I guess. There you go. Right? Just like basically diagonals will be special, I guess. Special. Right? So it's useful for you to make diagrams about the tongue especially, okay? So special sensation of the anterior special CN7, okay? Anterior 2/3 done by the CN7, okay? Important for you to note that. Right, let's get back into the PowerPoint. Right, there we go. Right. Once again, I just want to reiterate the cranial nerves that do the autonomics is 3, 7, 9, and 10. Right. So cranial nerve 7 does basically the majority of the autonomic of the face. Okay. And the buzzword here for the autonomic of the facial nerve is that despite the fact that it will go through the parotid gland, it does not supply the autonomic for the parotid gland. Okay, it's like a paradox. Okay, it will supply basically all the glands to the face, like almost all the glands except the one it goes through. So that's a little bit of bitchy thing to do. Okay, I want to kind of stress this because I don't think this was taught well at all when I was taught. Okay, when I was taught this. How can I get a pen? Oh, I can't even get a pen. Well, that's lame. Right. So let's start off with how it begins. Okay, so this is a simplified diagram, and I want you to look at this to see in like a 3D view ish, just so you can relate to how it goes when it goes through from the intercranial to the extracranial part. Okay, so it arises from the brain. I'm not going to describe this part. Okay, so these two roots go through the internal acoustic meatus. So that's what this is. The internal acoustic meatus in the brain. Forming into one big chunk, right? And when it gets to this point, when it gets inside here, near the ear, right? It forms something called the geniculate ganglion over here, okay? Geniculate ganglion before it breaks up into anything. Geniculate ganglion over here. And you'll realize also there's 4 major ganglions in the head, 4 major autonomic ganglion, okay? And geniculate is not one of them. I don't know why they called it this. I think it's a stupid misnomer. It's, you know, take of it what you will. Hey, son. Right. So the greater petrosal nerve, parasympathetic. Okay, right. So geniculate ganglion formed here or here, okay? Then, from the geniculate ganglion, it gives rise to a greater petrosal nerve, which will go out and basically provides all of the parasympathetic to the glands except parotid gland, okay? That's the first split. After the geniculate ganglion. It will then go through, okay? So this is pretty early on here. It will go through here when it's about to exit the ear. It will give 2 more nerves. Nerve to stapedius and the chorda tympani, which will also provide some special sensation to the tongue, okay? And I believe some parasympathetic as well. I believe. Right. Maybe. Okay, so nerves of stapedius and chorda tympani goes out into the ears, like basically splits before the ear. And this little, I'm not sure if you can see this, but this little bracket, or basically here, is the stylomastoid foramen, and that's when it'll break off into all the musculature nerves, right? What provides the muscles. Now, why did I go through that course? What's important about this course? Well, imagine this diagram as being this, just like 1,000 times more messy. So this little curve here, geniculate ganglion and the deep petrosal, geniculate ganglion, deep petrosal. Oh, oops. And then you got the middle stapedius and all that stuff, right? The important part to note is, maybe I'll use this picture because it's better. If you have a laceration after the geniculate ganglion, okay? So imagine I cut this part, okay? This part over here. You will expect someone to exhibit all facial nerve 7 pathology. So basically they can't move any of the muscle, they can't hear properly, and they can't taste a special sensation of taste in the posterior 2/3. But you will also note that if it's after the genicular ganglion, all their glands will work perfectly. Okay, because the parasympathetic has already bifurcated, it's already innervated, so they'll be able to cry, they'll be able to salivate, it'll be fine, or it should be fine. Okay, if it's before the genicular ganglion, nothing will work. No lacrimation, no hearing loss, nothing will actual hearing loss. Everything will be gone. And as you can also imagine, if there's a lesion outside, so if someone punches you in like very specific spot outside the stylomastoforamen and cuts that, you'll expect them to hear well, lacrimate, and salivary stuff. They can taste the anterior 2/3. They simply cannot move their face, right? That's an important point to know. And once again, rote learning, but you do need to know these 5 branches, right? I don't think you need to know which supplies what. Just know the general location. Okay. Yeah. Right. This autonomic component's important. This is important because this is one of the worst taught things in Monash, right? Once again, if you have any questions, just hit me up. Can you point at it in your mouse? Oh shit! Wait, it's supposed to have mouse capture on. Oh no. Does it not have mouse capture on? It says I've got mouse capture on. That's confusing. Okay, so that's horrid. Oh no. How do I even draw on this? I'm pretty sure I should be able to draw on this. Well, isn't that lame? Okay, hold on. Let me do something clever then. Right. Actually, sorry about this, guys. I did not realize that my mouse was not capturing. I was signaling a lot with my mouse. Oh no. Okay, let's do this. So I'm gonna basically transfer this over into the Flash. There you go. Okay, so I'm gonna transfer over now to the Flash. All right, there we go. Okay, so I'm gonna quickly run through what I just said. Okay. So important points to note. Okay, so this point, oh god, that is thick with 2 C's right there. Okay, let's go. Okay. There you go. That's better. That's much better. Right. So this is the genicular ganglion. Okay. Before it's bifurcates to the petrosal nerve, which is like round about the point there. Okay. Round about there. I don't know. Like, this one's not as specific. Okay. Over here. No, actually, no, never mind. That's the internal coastal meatus. Sorry, I meant to signal here. And then over here, it'll split off into the ear stuff, right? And then this is a stylomastoid foramen. Okay. Now, as you can imagine, if you cut at this point, you'll lose quad and tympani, you'll lose all the muscle, but you'll still expect normal hearing, normal lacrimation. Cut here, you lose hearing, and cut here, you'll lose the greater petrosal nerves. Therefore, you'll lose lacrimation and stuff. Okay, right? So that's that's the quick version. Was that okay? I'm sorry. There's mouse now. Okay. Whoops. Well, what a waste of time that was. If there was a mouse then. Right. Yeah, temporal zygomatic buccal module. Oh, okay. Important note to also know, they like to trip you up on this, is that these branches of the facial nerve are exactly that, branches. So do not confuse them, because I don't know why the people who made the nerves or named the nerves did this, but these are zygomatic branches and buccal branches, because trigeminal nerve, or CN5, has a zygomatic nerve and a buccal nerve. And they like to trip you up on that. So just be careful, okay? Just seriously, be careful about that. Right. Autonomic components. Right. Okay, so only carried by the chorda tympani and greater petrosal. So chorda tympani, as I mentioned, splits off within like basically after the ear. And this is when the confusion part, like when I mentioned the confusing part, comes in. So even though it leaves the infratemporal fossa, which you'll learn about in a few weeks, even though it leaves that, it actually joins the lingual nerve of the trigeminal nerve, so CN5, okay? So it attaches to that. It basically, when it says hitchhikes, it travels along with the lingual nerve, okay? And giving you the parasympathetic fibers, and forms something called the submandibular ganglion. And this is the first of the autonomic ganglion. So just write that in a separate page or something. The submandibular ganglion is the first autonomic ganglion that we've encountered, okay? And it's formed by the parasympathetic fibers of the chorda tympani, aka CN7. Okay, just remember that. Okay, and the reason this ganglion exists is so that it can split off and and supply the submandibular and sublingual salivary glands. Okay, so salivation of these two is done by the chorda tympani via the submandibular ganglion. Okay, and the chorda tympani, which also follows the lingual nerve, basically supplies special sensation of the anterior 2/3. And those of you who've studied ahead know where I'm going with the lingual nerve, but I'll mention that later. Okay. Greater petrosal nerve, this is the second ganglion we're going to come against, okay? So, arises distal to the genicular ganglion, travel across the middle cranial fossa, and across the foramen lacerum. It's important to know that. Once again, remember that the foramen lacerum, nothing goes through except the greater petrosal, or sorry, the combination of deep petrosal, I guess, and the carotid artery, right? So greater petrosal combines with the deep petrosal, and from this is the internal carotid plexus is just unimportant. It's basically an external combination of I believe sympathetic, no, parasympathetic, sorry, of the internal carotid plexus, which is no, okay, sorry. Let me rephrase that. It does go through the foramen lacerum combined with deep petrosal, but the internal carotid plexus is basically the parasympathetic fibers that go along the actual internal carotid artery itself, right? It goes up from the trunk, basically, not the trunk, but basically goes up and follows through. I think Lazarus really loves this point, and she gets really excited when she talks about this, but, you know, I think for me it's unimportant, and for you it's unimportant as well. Just know that it combines with deep petrosal, right, and forms the nerve of the pterygoid canal. And that's when it forms the second ganglion that we encountered, the pterygopalatine ganglion. Not as important, I admit, but all you need to know is that pterygopalatine ganglion supplies, the mucus glands, and especially the lacrimal gland. Because the confusion comes from, the common thing they like to test with the autonomic is, A, does the facial nerve 7 supply the parotid gland? No. Okay, and I'm getting ahead of myself, but the third ganglion that I'm probably going to touch on is the ciliary ganglion, which is around the eyes. And most people say, hey, that's the ciliary ganglion, it's next to the eyes, it does lacrimation, right? No. Okay, CN7 does lacrimation via the pterygopalatine ganglion. Okay, I know it's a lot of ganglions, and I'm saying that over and over, and I think it's drying in my mouth, but just note that and save it for later. Right. Give me a minute, because I think I hear something and I'm kind of afraid. So if I die on stream, I'm sorry. Love you. All right, be right back. Oh shit. Okay, I totally lied. I was getting a snack and water. Hey, that's what happens when you live stream, boys and girls. All right. So, what are we on now? Facial nerve. Okay, high yield stuff again. So this is actually one of the things that we still learn in third year. Okay, so once I get into the clinical stuff, I'll mention what's more high yield than others. But this is definitely something you should know, and I think I might draw this as well, just to kind of stress how important it is to know this. Okay, let me draw something. Let me draw this. I'm not as good as drawing as they are, so forgive me. Oh my god, I am not good at drawing. Okay, so let's first go over the details. Okay, no, I'm gonna draw this. Okay, so if we transfer over to my recording software. Oh, okay, awesome. Okay, so this little drawing here. Wait a minute. Uh-oh, my gear is glitching out. Oh no. Oh no. Oh no, that's embarrassing. There we go. Okay, let me show you this first. Yeah, let me show you this first. This is a fantastic diagram, and you should look at this and try to understand what I'm going to talk about, but I'm going to first draw it for you, okay? And hopefully you get what I'm trying to say with this, okay? So look at this diagram of this beautiful skull, okay? As you can tell, I have immaculate artistic talent, right? Now, as you would expect, so I'm going to color in different colors now. So imagine that this is imagine the brain, okay? What color is the brain? Pink. This is the brain, okay? Right? That's too many colors now. I'm going to delete that. So imagine the brain, and you already know that the things in the brain, they kind of decussate over to the other side and supply that, right? So let's first draw the left side or the right side. Okay, so this is the left side. It decussates, okay, it decussates, and as you can imagine, it supplies, let me zoom out, as you can imagine, it supplies the forehead and the lower face separately. Okay, this is facial nerve 7. This is very, very rough, but just imagine this is what it does, okay? And this is something you would imagine, right? Like your nerve decussates, goes one side, completely normal. However, the weird thing, maybe not the weird thing, but another thing it also does is it gives off a branch to the same side, so ipsilateral forehead, okay? And if you can also imagine this to be the case for the other nerve. So the right side's nerve also provides the forehead and the lower face, but also gives off to the ipsilateral forehead. So what's important about that? Okay, what's important? Oh, by the way, this is like the neuron point. I forgot that it actually starts up here and connects like that, but that's unimportant. Okay, good. That is kind of actually important. I should have mentioned that. So just imagine the brain is very large. So this is a very large brain. Okay, so this, what I just drew, is the upper motor neuron, and this lower part, all this little color-coded stuff, is the lower motor neuron. So Maz, why is that important? Okay, so as you can imagine, if I would have a stroke, my brain infarcts, okay, it dies on me, and a stroke is basically an upper motor neuron lesion. That's basically what it is. So imagine this dead, right? So what happens from then on is everything provided by this the beginning of this nerve is gone. So for example, I get rid of the orange, get rid of the orange side, boom, this is what happens. Okay, no, that's a blue side. This is what happens. So now it's easy to imagine what is left over. So if the orange is gone, what you will lose is the opposite side's complete lower face and the orange's supply of the forehead. But because the blue side has given the ipsilateral supply to the forehead, the patient will still be able to move their forehead. Even though they had a stroke, they will be able to move their forehead, okay? And that is why, very important, stroke is forehead, buzzword, sparing, okay? Forehead, look at my handwriting. I'm already a doctor. Okay, stroke. Okay, that's the easiest way I can describe this. Okay, stroke, forehead sparing. Similarly, other side, boom. Notice how this forehead still has supply. The other side has complete supply. Lower face does not. Forehead sparing. It has the sparing. Okay. However, what the basically Bell's palsy is, despite the fact that it's a diagnosis of exclusion, right? Basically meaning it's something you diagnose after everything else doesn't work. Even though it's a diagnosis of exclusion, it usually occurs to the lower motor neuron, okay? So lower motor neuron loss. And what the lower motor neuron is everything from this point onwards, okay? Right, so as you can imagine, if I were to cut from this point onwards, okay? So this point onwards, what would be missing is this point. Everything from the left side. You can imagine, because I cut that point, because that's what the stylomoister foramen is. I told him my drawing's not good. That means everything on that side is gone, okay? And even though it's got both supply for the forehead, because I've cut the nerve there, it's lost everything. So, Bell's palsy, and I don't like using Bell's palsy because it is possible to get an upper motor neuron Bell's palsy, but I'll classify this. Basically, not forehead sparing. Okay? And maybe a better way to think about it is... a stroke is an upper motor neuron lesion, right? Whereas Bell's palsy is a lower motor neuron lesion. Okay, so a lower motor neuron lesion will not have forehead sparing. Upper motor neuron will have forehead sparing. I hope you guys understood that. I hope that was okay. Sorry about my bad drawing. I swear it's not. I can actually animate. Hence why I have a YouTube channel dedicated to animation, right? Right, I hope that was okay. If not, look at this beautiful diagram that describes it much, much better. And all this explanation. Okay? Muscles of expression, you don't need to know this really that much. Right. Cranial nerve 5, let's go. Let me open my chips. Okay, cranial nerve 5. It's a derivative of the first pharyngeal arch. And you think like that's unimportant? It's important. Embryology matters. Oh, frick, I used her catchphrase. Okay? Right. The trigeminal nerve covers the majority of the face. No, it covers all the face, okay? It's the sensory component of just the normal sensation of the face, okay? It's the only thing responsible. You realize why I'm mentioning the cutaneous innervation is because you also have special sensation, as you know, with the lingual nerve, the chord and tympani. Damn it, I don't want to spoil it. But the chord and tympani, etc. Right? Now, one important thing you also need to know is that even though the three... Okay, let me actually explain that first. So trigeminal nerve, the reason it's called trigeminal is because it splits off into 3 nerves. Okay? The occipital nerve. What is wrong with the ophthalmic nerve, the maxillary nerve, and the mandibular nerve. Okay? And you'll realize why this is important later on. Okay? And once again, I just want to stress, even though cranial nerve 5 does not have autonomic supply, it does receive parasympathetic ganglia, and like it does form the parasympathetic ganglia because of the chorda tympani, right? Remember that. Okay, so the 3 nerves, ophthalmic, maxillary, mandibular, and you do need to know where it exits, okay? Right, fantastic. Now, ophthalmic nerve. What do you need to know about the ophthalmic nerve? So look at this diagram. Look at this. Look at this beautiful, beautiful Teach Me Anatomy diagram. I think it's Teach Me Anatomy. Okay. You need to know exactly where these lines are, okay? Because in an exam, we got the question, if you touch slightly below the eye, which nerve is that? And if you like, I know a few people who made a diagram in which they split that into 3 from the nose to the ear to the mouth to the ear. No, because there's some points like the end of your nose that is not ophthalmic nerve, okay? Whereas the bridge of your nose is ophthalmic nerve. The corner of your mouth is mandibular, whereas the top of your mouth is maxillary. The angle of the mandible, look at this, is not done by the mandibular nerve, okay? It covers almost all of it. And only the beginning of your ear, not the rest of the ear, only the beginning is done by the mandibular nerve, okay? These are very important points to know. And this is just cranial, cervical C1, C2, and then it obviously goes into your upper limb. Okay, right? Now, specifically about the ophthalmic nerve. Now, just a hint, ophthalmic nerve has 3 branches, okay? Frontal branch, lacrimal branch, and nasociliary branch, okay? I'm not going to go into specifics, but also note how the lacrimal branch enters the lacrimal gland, because if you recall correctly, the pterygopalatine ganglion follows this lacrimal branch and supplies the lacrimal gland. And I'm not going to touch on this at all until we start eyes, but the ophthalmic nerve CN5, okay, joins the ciliary ganglion. So this is the 3rd ganglion that I mentioned, but I'm not going to get into it, okay? Once again, I just want to stress out, pterygopalatine ganglion follows CNV2, right? Then it follows CNV1, so follow maxillary nerve, and then ophthalmic nerve to supply the lacrimal gland. It's something you just need to understand in your own time, but there you go. Oh, the most common mistake I saw people doing with this, the freaking maxillary nerve, is that they learned all the terminal branches. There are way too many, and they are not important. Do not do that, okay? What I do want you to learn, though, is some of it, okay? For example, the infraorbital nerve, pretty important. Nasopalatine and some of the palatine ones are pretty important. The infraorbital nerve is the one I'd say most important. Zygomatic nerve, I think in your slides, I actually made the rookie error of calling it zygomatic branch. If you could fix that, that would be great, and I think I used it one here as well. Zygomatic branch is what it actually is. Zygomatic nerve is what it actually is. Zygomatic branch is for the facial, okay? Look, I didn't make the names, they did. Okay. I already talked about this all the time, man. Holy. Alright, mandibular nerve. Now, this is when the important part comes on. All of the muscles supplied by terminal or trigeminal nerve is done by mandibular nerve. Every muscle is supplied by CNV3 or mandibular nerve, okay? Why did I not write that here? Oh, there it is, okay. It's all done by CNV3. The important nerve you need to know for this one is inferior alveolar nerve and lingual nerve, okay? And I think I'll get into that. Oh, no. Okay, I'll get into it right now. So, let's get this stupid one out of the way. So, buccal nerve, once again, not to be confused with buccal branch, it supplies the sensation of the cheek. And I mentioned the kind of paradox here, so you don't get confused. Lingual nerve, now, let's get back into the tongue. Let's get into the tongue we were drawing. not the skull, sorry. Not the skull. Let's get back into the tongue, okay? So, special C7, let's make the opposite diagonal normal. It's actually, let me first special and 2/3. There you go. Right now, the lingual nerve, and let's write the name as well. Chorda tympani. Okay, the lingual nerve does the general sensation of the front. So let's do the other way. Wow, my line. What? Do I have arthritis? What is that? That's disgusting. Alright, lingual nerve. Okay, and this is just general and 2/3 done by CNV3. Okay, very important to know. Very important. Don't get confused. Alright. Inferior alveolar nerve is important because, well, I have a full page dedicated to that, so I'll mention that later, okay? Yeah, okay. Yes, and this is the only nerve that does the muscles, and you just need to know it. And finally, the fourth ganglion that I won't currently get into is the otic ganglion, but I won't get into that until we get into your cranial nerve 9. Now, if you guys are sleeping or getting tired, listen up again, bitches. I shouldn't have called you bitches. I respect all of you. Please love me. Alright, so this is when we start clinical. And this clinical stuff is easily examinable. Will come up in your future as doctors. Well, maybe not. Maybe some of not the rare ones. But it will come up in your testing for future doctors. Sorry, took a swig of water midway through the sentence there. Nice. Right, danger triangle. So, as mentioned beforehand, remember how most of the face, especially this triangle, is drained by the ophthalmic veins to the cavernous sinus, okay? Now, what's wrong with that, okay? What's wrong with that? So, the reason is because if you have a little zit on the bridge of your nose, on the top of your lip, right? And I know most of you have had that and popped it and it's fine, but the danger of popping it is that if it can cause an infection underneath the skin, which can go through and get drained by the ophthalmic veins and therefore go to the cavernous sinus, okay? And the cavernous sinus, if it's infected, it can cause, because of how much blood is pooled there, it can cause a thrombosis, okay? Which can not only, like, you know, kill you, I guess, but it can also cause compression of your optic chiasm, which is right next to it, so causing bitemporal hemianopia. So that's when your lateral halves, I'm sure you've already studied this, but it's when you're, I'm not going to draw it, who cares? Right? It's basically bitemporal hemianopia. You can Google that to get a good image, okay? And compression of pituitary gland, right? And, oh, how did I not mention this? Did I mention it later? I didn't. Oh, man. I'm sure I did. Maybe you can control F and go, like find in the document. I'm 100% sure I did. But the cavernous sinus thrombosis or cavernous sinus blocks nerves in a specific order, and this may be the order. I'm not sure, right? But know the order because that is also tested often. Right? I'm sorry that I should could just control F it. I'm 100% sure I'm putting in my document. Okay. This is one of the questions in your anatomy workbook, and it's like a really easy answer. So basically, why do scalp lacerations bleed so much? Okay, it's because the occipital frontalis epicranial aponeurosis, wow, that's a mouthful, is so strong on the fact that if you cut your scalp, the aponeurosis basically stretched the wound open, okay, because of how strong the muscle is. And because of how well your scalp is also vascular. The vascular supply of the scalp is so profuse that when you have such a deep, such a open wound that's furthered by the epicranial aponeurosis, you just bleed a lot, right? Furthermore, the arteries, which usually contract to stop the bleeding, it can't contract because of the connective tissue. So it's like a trifecta of problems. 1, the aponeurosis stretched too much. 2, too much anastomosis to the point where it's like you'll bleed out profusely regardless. And 3, the dense connective tissue holds the arterial walls apart and prevents contraction, therefore exacerbating the bleed. Obviously, I mentioned this before, loose connective tissue is most dangerous because an infection can go into the durovenous sinus, and that's bad. This has been examined from the ends of time, okay? Learn this. Learn this. Holy shit. Okay? Right. Let's go through this. Epidural hematoma. And most tutors, they'll tell you like how to diagnose and what to look for and stuff. But I want to tell you in a real life patient, okay? So what causes, what's important, you need to know for all 3, what causes it. So epidural hematoma, and you better know this, guys. You better know this, but it's a torn middle meningeal artery caused by perhaps a fracture of the pterion. Okay, and it occurs from trauma. There's no specific age group. I guess perhaps like anyone who's more susceptible to fractures. I don't know, like the elderly. But no, there's no specific age group. It's just trauma. Okay, so someone comes in, swings a bat upside your head, tears your middle meningeal artery, and it is called a red lemon, okay? And if you don't want to sound like a complete dope on your OSCEs by calling it a red lemon, call it an arterial space-occupying lesion that is a convex arterial bleed or hematoma, okay? Convex. So basically red lemon, right? It causes a red-like lemon because of the arterial bleed. And why does it cause a lemon? Okay, do any of you know? Damn it, I can't ask any of you. Okay, so the reason it causes a lemon shape instead of a concave shape and causes a convex shape is because it's an extradural. Okay, and what's important about that is because the dura mater is actually concentrated more on the sutures of the skull. Okay, so you'll notice that these two points line up perfectly with some of the sutures of the actual skull, right? And so because there's some extra dura mater there, it bleeds and it basically can't rip apart those sutures and it keeps collecting and restricted by that space, right? Whereas a subdural is not restricted by that space because it's in subdural hematoma and it can just go around and be evenly spread, okay? Now, the clinical thing you need to know as well is that someone comes in, swings a bat across your head, tears your middle meningeal artery, red lemon, but then the person, even though they have a brief concussion, they're like, I'm so dizzy. They get up and they're like, dude, I'm completely fine. I don't need to go to the hospital. I'm fine. Okay, I'm really fine. And that's something called a lucid interval. Okay, they have a brief concussion and they get complete consciousness and they're like, they will be completely okay. And they'll go home, you'll send them off in a taxi, but then like 10 or 15 minutes later, they'll quickly quickly go into drowsiness and then coma, because obviously there's a hematoma in their brain, right? That occupies a space that very obvious. So that's why if anyone gets hit in the head, that's the reason that people all the TV shows, it's like, I have a concussion, I can go. It's like, no, you can't. They're worried that you have an extradural hematoma. Okay, right. Subdural hematoma. Okay. I actually want an answers to this, because this is something that might test your knowledge, or perhaps your ability to read books or Google, assholes. But with a subdural hematoma, I wrote, from a hard blow that jerks brain inside a cranium and injures it. Do you know of any population group that is in greater risk of that occurring? Why did I specify it like that? Okay? If you can comment on the YouTube live chat, I'd love it, but I'm not going to tell you until I get someone answering. Okay? So, this is not the most correct answer from tearing of superior cerebral veins. Not the best answer. I actually might change that. Change that to bridging veins. Okay? The most common veins that are torn because of a subdural hematoma is the bridging veins. So, if I were to go up here, this vein that connects the dural sinus, okay, which is in the dural, like in the obviously the dural mater, down into like the pia / cerebrum. That's what gets torn. Because as you can imagine, from a hard blow that jerks brain inside cranium, so if the brain shakes, that bridging vein snaps and causes a venous bleed or a blue banana, okay, and that causes the headache, okay, that causes the headache. And this is just a headache. There's no specific term, but this is a headache that gets worse until treatment. So unless you get better, or death. Okay. So like if this happens, and someone says, "Oh, I've got a pretty bad headache," and it's like, "Oh, it's getting worse. Oh, it's getting worse and worse and worse," they've got a subdural. Okay. Right. And no one answered. Wow, no one answered for who's at risk. But the important thing, so extradural is because of trauma. Subdural is there are two groups that are greater risk of a subdural hematoma. The elderly, because they've grown to the point where their brain starts to atrophy, and so they have a big, like, normal skull in a normal skull with a kind of atrophied brain, and so the distance, as you can imagine, the distance between this and that is greater, so they can, if they fall or there's a shearing force, they can snap that pretty easily. The second is babies. Babies are at risk. Babies are at risk, like to an sorry, I just got a text message. Why are your Vespimps people so rude when you give all your shut up. Okay, so what was it saying? Oh yeah, babies. Okay, so why are babies greater at risk? Because of shaken baby syndrome. So as you can imagine, the elderly people have atrophied brain with normal skull, whereas babies have a growing skull with tiny brain. Okay, so shake the baby, shake it up, boom. You've torn their bridging veins and you've given them a subdural hematoma. Okay, rest in peace, baby. Okay, and lastly is the subarachnoid hemorrhage. Now, why did I call it hematoma and hemorrhage? Because hematomas are not a open bleed. They're just a collection of blood, that's trapped within itself. Whereas the hemorrhage, subarachnoid hemorrhage, is just an open bleed that's going everywhere, right? So, what's greater at risk? So the cause of this, the cause of this is a saccular aneurysm or berry aneurysm, or basically stroke. It's a stroke, right? A saccular aneurysm or buzzword berry aneurysm. Those two words are the correct terms. I think more people use berry aneurysm. Saccular is what they use in the textbooks, okay? And the people who are at risk is basically those at hypertension. If you have hypertension, you're more at risk of berry aneurysm, okay? And it's arterial. Now, how do they present? It presents with very sudden onset headache, which is described as a thunderclap. So they'll be driving one day and they'll just go and it'll be like an incredibly severe headache. And because it's also within the meninges, it will cause meningeal irritation, so they'll have like stiff neck, they want to vomit, they might lose consciousness because of how severe it is, okay? And it's a medical emergency. Oh, it's an emergency, right? So you can also figure it out. So red lemon, blue banana, and what's this? So this is typically called the starfish sign or the crab of death, okay? So if you see, it could notice how it's really dark for both of them, whereas this one's really bright, right? Like really lit up because of the subarachnoid hemorrhage, right? And this is some better examples, better images. And you can see the sutures. The sutures are held here. Oh, okay. Alright, okay, so damage to facial nerve, we're almost there, guys. I've already mentioned this, but once again, I just want to reiterate. Chorda tympani, if you cut that, you not only have reduced salivation, because remember, it forms the submandibular ganglion, and therefore you lose the submandibular and submental glands. You also lose the loss of special taste on the 2/3 of your tongue, okay? Ipsilateral, that's important. Remember the stupid skull, okay? Remember the stupid skull. Nerve to stapedius. Stapedius is basically important for hearing, so if that goes away, it's ipsilateral as well, and you basically hypersensitive to sound. Everything is too loud to you. And lastly, greater petrosal nerve, ipsilateral once again. If you cut that, you get reduced lacrimal fluid. Okay, remember to ask. Well, not to ask. It's a clinical diagnosis. So if you see they're able to lacrimate, they're able to perhaps taste, but then they're not able to lacrimate. They are able to taste, but they're not able to hear properly. You can kind of guess where the laceration was, right? Now this is getting a bit too specific. Just look at the highlighted parts, because I actually met a patient recently with Bell's palsy and they had all of these symptoms, okay? So they're unable to move. Okay, so quick question, which side has the Bell's palsy? Okay? Ignore the fact that I wrote right side. Right-sided Bell's palsy. Alright, there we go. So it's the right-sided Bell's palsy. It's this side, okay? Because of the inability to wrinkle the forehead like on the other side. They can't smile. They can't crinkle their eyes. Nothing works here, okay? And so what they'll appear is that they appear sad. They can't really produce fluid, but remember that's dependent upon the laceration, the point of laceration. Removal of finger. So sometimes they can't, well, not sometimes, they can't chew really well. So they'll remove, and the oral vestibule is the space between the front of your teeth and the back of like your lips. So that area there, they have to keep using their fingers to scoop it out and put it into actual mouth, right? Because they can't use their buccinators well enough to stick against your teeth, right? They also have drooping of the mouth, so their saliva comes out. And this is the most notable one that I found, was that they actually cannot pronounce labial sounds. So the patient that I saw, they were like, like they couldn't say the bit of his trouble, right? So they were like, it's a it of a elbow, like they couldn't say it. And obviously they can't play instruments. I don't know why you're giving someone with Bell's palsy like a flute and go play for me, but you know, obviously they can't. What causes it? Parotid gland pathology, because it goes through the parotid gland. If something goes wrong, you're screwed. And herpes. Herpes can cause any of the nerves to go haywire. Once again, Bell's palsy is a diagnosis of exclusion. You have to first figure out if it's stroke. Forehead sparing sometimes isn't the best marker. You just have to investigate as much as you can. Ramsay-Hunt syndrome can cause the same kind of symptoms, except they have blisters, since it's caused by herpes. And then once everything's ruled out, then you can say it's Bell's palsy. Inferior alveolar nerve block. Alright, so this is the one that I kind of skipped over. So once again, it's a branch of the mandibular nerve that goes through the mandibular foramen down here. You will learn this again when you touch into mandible and stuff, but I do want to mention that this is what the dentists inject to when they want to kind of numb your teeth. Okay, they inject into this mandibular foramen into the to stop the inferior alveolar nerve, because then that numbs your lower limbs and chin. Okay, and then they can just go at it, right? However, a poor dentist, not like rich, but a bad dentist, may not put it in the right place, and they may affect the lingual nerve. And that's why for some of you, and I know for this happened to me, it affects the anterior 2/3 of your tongue as well. And it's interesting because yeah, it affects into 2/3, but a really bad dentist may inject near your parotid gland. I'm not sure what they're doing there, but then that will affect your CN7. So you won't be able to use that side of the mouth or facial muscle properly. So if you have that, if a dentist does that to you, get a new dentist. Right. I won't go through clinical examination. That's for your own time, because that's literally what's in your textbook and an explanation of one of the reflexes. But I will go through this because I found this interesting. So trigeminal neuralgia. There are a few conditions in the human body in which the pain is so intense that a risk factor is actually suicide because of how badly the patient wants to stop the pain. And this trigeminal neuralgia is one of them. So patients with trigeminal neuralgia, well, no, obviously not every case, but there are some cases that are that severe. Some patients will explain that they have episodes of sudden pain and then it goes back down, whereas other patients will explain that they have very constant pain that fluctuates from just a dull to just a flaming roaring of pain, okay? And it's basically caused by the accessory meningeal artery or the superior cerebral artery kind of compressing upon the nerve, okay? And this is buzzword here. I don't know why I didn't turn this, like, highlight that. But it's set off by touching your face or day-to-day activities. So brushing your hair, brushing your teeth, is like common things they do to set off this trigeminal neuralgia, right? And it's so severe that it can cause wincing when it happens, depression, or suicide attempts. So you need to get this sorted ASAP, okay? The most common nerve that's affected, CNV2, then 3, then 1. 2, 3, 1, okay? And can also occur during herpes, but herpes affects 1. These 2 points you just need to rote learn. And since I'm skipping over clinical examination, I think that is it. I think that's it. I hope that was okay. I hope that was okay. There was a kind of long-ish session. Yeah, I'm glad that we're finally over. I'm really hungry. Thank you guys for sticking around. Yeah, you know what? I might not upload this later because I'm feeling kind of petty right now. No, I'm kidding. I'll probably upload it. All right. The first week isn't as high yield as I wanted. It's not as high yield as you would expect. The more high yield stuff is because you have McMiniman. I is super high yield. He loves that stuff. And we didn't even touch on the posterior tongue, but we'll get to that, okay? So thanks for coming, guys. If you want to donate money to me, you can. I have a Patreon set up. I'm kidding. I'm not kidding. Pay me. All right. Laters, guys.